ASRH programs. This webinar is the third in a series which is hosted by the Very Young Adolescents Alliance, or what we sometimes refer to as VYAs. The VYA Alliance started as a consortium of members, including, oh gosh, I don't speak German, DSW, the Institute for Reproductive Health at Georgetown University, or IRH, Plan International USA, and Save the Children. And since 2010, those organizations have been working together to catalyze action to meet the needs of very young adolescents globally through their work and as a community of practice. The VYA Alliance now sits under the Passages Project, which was a newly awarded project supported by USAID, which was awarded to Georgetown University. Great story goes from formative research to scale, and we're going to give an overview of each of GREAT's intervention components, how they were used, the key results that were obtained, and the lessons learned, and then we'll have some conversation about how GREAT is being scaled up. We hope to have time at the end for questions and answers, so please do submit your questions via the chat box in the corner of your screen, and we'll try to collect your questions throughout and share them with our panelists at the end. So we have a very robust group of presenters this morning, and we're just going to go to the first panelist this morning. Just so you know, we are calling in from different parts of the globe, Washington, Boston, and Uganda, so if we do have some connectivity problems, please bear with us. Our first panelist this morning is Nana Dagadu. Nana has a Master's in Public Health, and she's the Program Officer for Monitoring and Evaluation at Georgetown University's Institute for Reproductive Health. Nana is responsible for supporting MLE, Monitoring, Learning, and Evaluation, research, and technical assistance efforts across all of the Institute's projects, which include GREAT, the Real Fathers Initiative, FACT, which is a fertility awareness project, and A3. Nana has worked on a range of issues on sexual and reproductive health and HIV/AIDS to emergency relief and assistance. And this morning, Nana is going to give us a very brief overview of the GREAT project. So I'm going to turn it over to Nana now to give you some of the background information on GREAT.
Thank you, Kate. We're excited to share the GREAT implementation story with you today. So I'll give an introduction to the project, and then I'll turn the mic over to my colleagues, especially those in Uganda, who are graciously dealing with connectivity issues and a late hour to bring the true field perspective. Next slide, please. They will share their successes and challenges in rolling out the 4 GREAT components and their takeaways from Scale Up. We hope you'll reflect as you listen and share questions and experiences about the realities of doing work to shift social norms and change behaviors. Next slide. The GREAT project is a 6.5-year USAID-funded project. It is implemented by the Institute for Reproductive Health with Pathfinder International and Save the Children International with their respective partners, Concerned Parents Association and Straight Talk Foundation in Amuru and Lira districts of northern Uganda, to improve the gender equality and reproductive health outcomes among adolescents 10 to 19 and their communities. Next slide, please. Designed as a research project, GREAT was implemented with some phasing. So in phase 1, which was years 1 to 2, we conducted rigorous formative research, speaking with target populations and reviewing existing programs. This contributed to a creative brief which laid out the desired outcomes per theme and for each cohort. We also worked to set up a technical advisory group to guide the process and build ownership in the process. During phase 2, we implemented the designed project and also conducted rigorous monitoring, learning, and evaluation to keep track of the package as we went along. Starting in year 5, just last year, in phase 3, we prepared for and began implementing Scale Up. Next. We designed the intervention with key principles in mind. The principles are here on the slide, but I'll just talk through them briefly. First, we wanted to look at shifting social norms and attitudes to foster healthier, more equitable behaviors by correcting misinformation, encouraging critical reflection and dialogue, changing expectations for appropriate behavior, and really supporting groups to take action. Secondly, we wanted to focus on life course transitions when adolescents learn new roles and social norms. For example, children entering puberty, women and men entering marriage, and individuals becoming new parents. Thirdly, we wanted to diffuse new ideas and information through different levels of the community in order to support individual change. Fourth, we wanted to engage girls and boys, whether apart or together, but always in a relational interaction. And then finally, we wanted to reach the majority of people within existing groups and really with modest resources in time and money. So the resulting package was comprised of 4 components. The first, the community action cycle, which really goes to build community mobilization. The second, the radio drama to diffuse information. The third, working to orient village health team members on youth-friendly services in order to link adolescents to health services. And finally, the working with existing community groups using a toolkit to foster critical reflection. Next, please. Throughout the pilot, we used quantitative and qualitative methods to provide evidence that informed decisions about implementation and ultimately scale up. So we had a baseline end-line survey as well as a cohort study with 60 adolescents at 4 key moments in time, 6 months apart, and then also looking at a qualitative assessment to see how they were actually interfacing with the interventions, and then consistent monitoring. But really, reflections among our consortium members and with local communities and leaders were essential to adjustments and learning throughout the process. We found that young people and adults enjoyed being involved in GREAT and felt that it resulted in positive changes in themselves, their families, and their communities. Participation in GREAT activities helped to change attitudes related to men and women's roles, relationships, sex, family planning, and gender-based violence. We found that effects were somewhat more marked among men and the newly married and parenting. However, we did see that change is a complicated process to navigate and really requires us working on various factors at various levels. Adults exposed to GREAT were also significantly more likely to give young people advice on the topics of gender-based violence, sexual and reproductive health, and gender equality, which was great for the enabling environment. Next, please. With the results from the pilot, our team made slight adjustments to the package and prepared for scaling up to Oyam and Pade districts, here on the slide in green, and working with FHI 360's trained village health teams in Agago and Dokolo districts in the light green shaded regions on your slides. So I will now turn it over to my colleagues who will share the details of the adjustments to the intervention package and the scale-up efforts.
Thank you, Nana. I think one of the things I really like about this project is its real deliberate attempt to begin to challenge social norms, which are so important in terms of our ability to reach young people with information and ensuring their ability to act on that information to access services. So we're going to turn it over now to Uganda, and we're bringing in Dickens Ojamuge, who's the program manager for sexual and reproductive health and gender-based violence at Save the Children. He is the team leader for implementing the GREAT project, the responsible, engaged, and loving Fathers Project or the Real Fathers Project, and the Fertility Awareness for Community Transformation Project in SAVE's office in Gulu, Uganda. With more than 15 years of experience in community mobilization for health activities, Dickens is going to take us through the work that was done under GREAT around using the community action cycle to mobilize community. So thank you, Dickens. Over to you.
Thank you, Kate, and it's my pleasure to make a presentation on how we use CAC for mobilizing communities. Let's go to the next slide. Next slide. We go straight to the what we call the 5 Ws of community action cycle. Why did we use CAC? CAC was used to empower communities for social norm reflection and for change. And who implemented CAC? Community action cycle groups were responsible for the implementation of CAC, and each community, they had a group of at least 9 members with the support of our resource team. And the resource team here, we are talking about the staff from the implementing partner organization, Straight Talk Foundation and CPA. And where was CAC implemented? Definitely as a community mobilization tool, CAC was implemented at parish level, and we also implemented it at the village level where the great innovations or interventions were implemented. And when was CAC, when was it used? CAC was used, as was described by Nana, as the first step used by GREAT for stepping into the community and laying a foundation for engagement and social norm change discussions. And what is CAC in itself? CAC means to empower communities to organize themselves for action, to explore a development issue or a health issue, to plan on it, to act on it, evaluate it, and say, you know, how it has succeeded. Next slide. These are the steps of CAC. CAC is quite very systematic. If you are to do effective community mobilization, then you need to prepare your team to do the mobilization. You form a community mobilization team. Then you need to organize communities for action. That is the first engagement with communities. Then you bring the communities to explore on the subject matter, on the development or the health matter, and set priorities. Then you plan together with the community, and you act together with the community. It is at this point, number 4, number 5, where the community action groups take over. Then you are able to evaluate together, and then you prepare to do scale up, which more or less GREAT project is at the moment. Next slide. Next slide. The pilot phase CAC activities for community action cycle. We had the CAGs as the central group that was responsible for community mobilization. We had 301 trained CAGs and who were involved in the implementation. Their ages ranged between, you can't believe it, between 25 to 70 years, and they were both male and female, although they were mainly dominated by the male. The membership was the community health workers, the teachers, the local council members, the parents, and community members. The sex, as I said, was mixed, male and female. The sample activities for the community action groups included sensitizations and reflections on norms and values, and they also used the fireside chats in the evening, what they call Wango in Acholi. They also did the home visits, and then the meeting locations for the CAG activities were mainly in the trading centers, in the markets, in the schools, in the community group meeting points, in the churches after prayers, and also under some big trees dotted in the community. Assessing and evaluating CAC, and the purpose why we did this was because we wanted to do some learning and also to get the communications which took place during the CAC implementation. The methods we used the most significant change methodology. We used the focus group discussion, and we reviewed the materials. And from the most significant change stories, we interviewed community action group members 83, community members 75, community mobilizers, we interviewed 13, and 6 extension workers, and the project implementation group, that is the technical team where I belong, 5 of us were interviewed. What are the results, significant results that we saw CAC contributing? Next slide. This is what we saw. from the significant stories. There was, from the stories, increased support for the girls' education, including the very young adolescents, as I will state in one of the stories. There was decreased rates of GBV from the information that we got back from the community leaders. There was reduced alcohol use, and there was improved family planning, sexual reproductive health, related attitudes and behavior. Improved family dynamics in terms of relationships between partners and parents and children. Improved sharing of household chores and child care, and institutional support, with the linkages with the health facilities for reproductive health services and gender-related issues. Next slide. These are now the real stories that we had. This is one of the beneficiaries who had 7 children, and she wanted to took family planning. She said, I used to give birth so frequently that my children all look like they are almost of the same age. And today, I am on family planning. With no disturbance from pregnancy, I am working harder than before and educating my children. And this lady actually said she had put a full stop. She's not going to get another child now with family planning. Next slide. And another beneficiary, this is a case of the teenage girls who dropped from school and got into a relationship, and the community action group member went out and looked for these girls, and he said, we looked for them, reached out and encouraged them to rejoin school again. Now, early marriages has stopped at Olang Mio Primary School. This was a very wonderful case of 5 girls, because this is quite a common case in northern Uganda. Next slide. Next slide. Next slide. This is now from the extension worker. This is from Concerned Parents Association, from Straight Talk Foundation. And for him, he appreciated the power of CAC in mobilizing the communities. And this gentleman said, so CAC has got that where you move step by step to organize or mobilize these community members to let them buy in, to let them understand that this is really some issue and some problem in their community, and they need to take action on it. Next slide. I am moving to my last slide, I think. Yeah, lessons learned. Yes, next slide. From our experience, I want to share with you the lessons we learned. Successes. CAC as a method of general community development has been embraced because of its power in mobilizing and organizing the community. Community ownership, the buy-in was definitely realized, and we noted the contribution in the shifting of the norms from the stories we had on sexual reproductive health, gender roles, GBV, and by getting communities to discuss and space to reflect. That is the power of community action cycle. Next slide. Challenges. The motivation of the CAGs. They are volunteers, but in many cases they would forget that they are working for the community. Then they get back and say at least they need to be supported with some stipend for them to be able to move on. But also getting the coverage was also a bit of a challenge, because the CAGs we trained worked in their own communities. Female leadership was quite a challenge, because most of the leaders came from the normal community leadership dominated by the men. Evaluating CAC in isolation from other great components, it may be hard a little bit to isolate CAC, since these were interwoven interventions just to pull out CAC alone, but still we recognize its contribution. CAC requires effort to internalize and adapt it, because it has a step-by-step approach. And then activities of CAC, of the CAGs and the CMT were affected by the transfers, especially by the civil servants who are transferred from one place to the other, and the CAGs where the teachers used to belong were also affected. Thank you so much for listening to me. That is our story of using community action cycle for mobilizing communities for change. Thank you.
Thank you, Dickens. I'm so glad you were able to join us from rural Uganda. And we had some challenges yesterday in terms of Dickens connectivity, so it's great that you were able to join us today and to talk about the important work that you've done. I think one of the one of the most interesting aspects of GREAT is its very deliberate and systematic approach to adolescent health changes. And using the community action cycle is certainly a slow process, but it's incredibly important in terms of being able to embed these changes within communities. So again, thanks so much for telling us about your experiences in using the community action cycle. So from here, from Dickens, we're transitioning back to the United States, and we have Camille Collins-Lavelle, who has a master's in public health and is a technical advisor for community engagement at Pathfinder International. And Camille supports projects including the development of tools and approaches for community health workers, using mHealth for adolescent and youth sexual and reproductive health. These include things like interactive games for peer educators and the production and use of realistic fictional narratives as a basis for small group reflection and group action planning. And Camille is going to talk to us this morning about the use of radio and radio serial drama, which was used to disseminate information and I think also to reinforce some of the normative change that was occurring, that was being stimulated by the community action cycle. So, Camille.
Thanks, Kate, and thanks, Nana and Dickens, also for providing this context for what I'm about to talk about. I think one of the really impressive things about GREAT that I've appreciated is the synergy between all these pieces that we're describing. So now I'm going to tell you about the radio serial drama piece, and on the next slide, I would like to say a little bit about why radio serial drama was chosen as a piece of the GREAT project, and that is because there is some very good evidence already that radio dramas, long-running serial radio dramas, can be effective at changing knowledge, attitudes, and behaviors, self-reported behaviors. And maybe the best example of this is from Tanzania. There was a radio drama in the 1990s that was thoroughly evaluated, and that's one of the reasons why we decided to go forward with this. And again, the intention behind the drama is to stimulate discussion, and it was very attractive also because since we're thinking about scaling up from the beginning, this was an approach that was going to allow extensive, sorry, my microphone was up, allow extensive coverage and also would be a scalable approach. Next slide, please. One of the challenges was using the formative research. There was excellent formative research that we could use to design the content of the drama, but the trick was how do we get script writers to make a really good use of this data. So we used a game that it encourages, or it helps designers of radio dramas to take research results and use principles of social and behavior change theory to design a long-running story. And a quick description of this is that as we play the game, this tool requires the user to pull out personal, social, and environmental factors, both barriers and facilitators of the kinds of individual and social behaviors that we would like to see, so that the writers are drawing from the formative research and making sure that a full range of influential factors are being described in the drama. Next slide. Now that process of playing the game and really getting our local script writers from an organization called CDFU, it was wonderful to work with them, to get them to delve into the data and use it as they design their stories. The next stage was designing character trajectories for main characters that reflected the different target groups, so very young adolescents, unmarried young people, and then recently married young people, and then also the broader community. So we had different storylines and character trajectories for these different groups to make sure that the change was consistent with what we know about real behavior change and with the stages of change model behavior change. So you'll see at the bottom of this some charts where we really made sure that characters were moving through the stages of change in a realistic way and facing these barriers and facilitators at those 3 levels that I just mentioned. You can also see in the photograph how we charted out the stories and also some of the mapping that we did to make sure that the village in the drama and the characters were realistic and very similar to what people would actually be facing in their real lives. Next slide, please. So the result of this process was a drama that had intergenerational story, meaning characters from all these different groups relating to one another, and so just as it was mentioned before, making sure that we showing relationships between boys and girls and between men and women. And not all of, so this drama, it's important to say, it's not just about modeling positive behaviors, it's really about showing the realistic interactions so that people can then discuss this, and in some cases, as the change happens towards the end of the drama, there's more modeling going on. We had 50 half-an-hour episodes, so these were aired 1 per week over the course of a year, and there was a repetition of each episode later in the week, so that if somebody missed it, they could hear it again, and we had multiple broadcasters working. Something that's particularly interesting about this drama is that we did use 2 local languages, Lango and Acholi, but in one drama. So there's interaction between the languages, and this is something we were unsure of at first, but it was effective, and people were understanding both languages, and it gave us a chance to address also some of the contextual issues about different cultural groups in the same area in a post-conflict setting. And we had 4 main storylines, which I already mentioned, corresponding to each of our main groups, of specific life stage groups. And we also had a theme song which was created by a local youth group for the radio drama, and sometimes I think this might have been the most popular part of the drama. We heard a lot about how much people enjoyed hearing young people from their own communities singing this song, and it became a real signature piece. Next slide, please. Some supportive elements for the drama were talking points that we developed about gender and adolescent sexual reproductive health for the DJs and presenters at the radio stations. So we wanted to make sure that as they were introducing the drama or talking about it on the air later, that they would have the language that they needed and the ideas that they needed to be able to talk about this in a way that was consistent with our objectives. So there was some accompaniment for the DJs. There were community launch ceremonies to let people know that this drama was on the air and they could listen. And then some more traditional promotion flyers and spots that were used. And then there were the linkages between the drama and the other great activities and components. So there was, as part of the toolkit that Brad's going to describe in a bit, there were radio discussion guides, which interestingly enough were not used as much as we might have hoped, but we can talk about that a bit later. So I think again, just reminding us that this is all part of a package. So these are the results that we can link either to the drama or to the whole package. So we have 60% of all the survey respondents were exposed to the great interventions, to something in the package. And of those people, 94% were exposed to the radio serial drama. So we can see the radio serial drama did have, as we had hoped, good reach. 40% of all the listeners reported discussing topics that they'd heard about on the radio serial drama with other people, especially peers. 71% of the men that we interviewed reported listening to the drama, as compared to only 48% of women. Now that's a very interesting point, I think, because it means 2 things. It means that we may need to do a better job at reaching women and understand what the obstacles are to women for listening, but also it means that the story is compelling to men, which is very important because of the content, and so it's also really great to know that men are listening to this. And also really important to mention that even though our study was originally set up to have a control arm, one of the things that's very difficult about radio is that it's broad, and so we were reaching a lot of people in the control arm as well. So both intervention and control arm were exposed to the radio drama. We know that 48% of the population in the control arm that we surveyed also said, yeah, we heard the drama, compared to 66% in the intervention arm. Next slide, please. So if we want to look specifically at how different components of the Great Intervention, what their reach was, we can see that that radio was able to reach a larger portion of the population than other components of the toolkit, which is not surprising. But it was surprising to us that there was good listenership between the youngest age group there, 10 to 14. We had 78% who reported listening to the drama. We also have VHTs listening, and I think sorry, got that wrong. We also see that the other groups, the 15 to 19, the newly married, newly parenting, and adults also have pretty high levels of listenership, and we can compare that to their exposure to the VHT intervention in the following column. And we can also look at their overall exposure, and we can see that the 10 to 14-year-old has the highest exposure to the toolkit, which is also expected. Okay, next slide. Oh, and even as you go on to the next slide, I'll just mention that one of the things about the radio drama that we may have underestimated the exposure because we required that people remember the name of the drama in order to count that as exposure. And sometimes people had heard radio drama, they'd heard something on the radio, but they couldn't remember what the name was or which one it was, and so that was not counted as exposure. And now, starting to wrap up here, we know that 44% of married and parenting adolescents were currently using contraception versus what we would have expected in the absence of exposure, which was 33%. And I think Nana can answer questions also later about how we came up with these calculations about what was expected versus what was observed. 69% of couples in which one or both were exposed to the Great Intervention discussed contraception together with each other in the last 3 months versus only 57% would have been expected in the absence of exposure. And then finally, 52% of respondents reported that they or their partners were involved in childcare in the past week versus what would have been expected, 42% in the absence of exposure. So we're seeing changes in both gender-related behavior in the home and also family planning and other sexual health indicators and practices. So finally, our lessons learned. Next slide. We know that the radio drama was the primary way in which people were exposed to the Great Intervention. The storytelling element of the drama is what brings people in, and when they find it entertaining and also relevant and realistic to their own lives, it draws people in. However, it's not just the entertainment value. We do think that there's a lot of prompting to think about things differently and to discuss things, especially when new ideas are presented. The discussion guides probably require more active facilitation to be useful, and so they may be more appropriate for use with groups where there are leaders who have experience with facilitation or adult leaders who can take people through the radio drama discussion guides. And it's also really important to find appropriate days and times to make sure that all of our intended audience is able to listen. So we do have a bit more information about why women or why younger people, why certain groups maybe had more difficulty accessing the radio because of the time of day or competing other people in the home who wanted to use the radio for something else. So we have some data on that will be useful in the future. Next slide. Okay, so that's just to wrap it up. I wanted to say that I think the goal of having an intervention which would have large reach to involve more people in the project was successful, but that the synergy between the different components is a really important part of GREAT. Thanks for your time and attention.
Thanks, Camille. I'm a huge fan of radio. I think it still remains an important source of information, and these radio serial dramas, I think, are a really useful way around promoting social normative change, especially in some of these rural communities where radio is still a really important source of entertainment as well as information. So now we're going to transition back to Uganda, where Emily Katamujuna is going to talk to us a little bit more about the work that was done with the village health teams, in terms of raising the community action cycle, and the radio dramas I think are important in terms of information and raising awareness, but ultimately we want people to begin to take some steps in terms of health behavior and improving their use of contraception. So Emily is who's the project manager for GREAT, the GREAT project and the Positive Action for Children's Fund project at Pathfinder International, is going to talk to us about that work with the village health teams. Emily has over 15 years of experience in promoting, designing, implementing, and monitoring projects in HIV/AIDS, OVC programs, malaria, and more. And she obtained her master's in public health from Makerere University School of Public Health in Kampala, Uganda. Thanks, Emily. We're very much interested in hearing more about your work with the village health teams.
Thank you very much, Kate, and thank you, the previous presenters. I would like to add my voice to the previous presenter and talk about another strategy that GREAT used, the ASRH, Sexual Reproductive Health Service Linkages, and working with VHTS. GREAT focused on changing gender norms and catalyzing demand for services. And access to service is critical when generating demand. It is important here to mention that while we had the sexual reproductive health services linkages, the adolescents in the northern Uganda face multiple barriers to accessing ASRH services. Next. What GREAT service linkage strategy was made up of mainly three important components. First, we used the existing system, which was more scalable, and under this we did mapping of all the village health teams and mapping of the existing health and social service sources, because this was very important in that for the VHTs to do referrals, they needed to work with the village health teams. The village health teams, these were community health workers, officially whose role was to work between the community and the health facilities for referral purposes. Their other mandate was provide family planning counseling, including even other occasional methods, and opportunity to increase access to information and services at community level for adolescents through additional training and support. And still under the GREAT strategy, we did not stop there. We had to involve also the district health centers in the intervention areas, because these had a key role of doing supervisory work. Next. Who are the VHTs? The VHTs in full is village health teams, and these were volunteers at the community health who were part of the public health systems of Uganda, and they were working as an important link between the community and the health facilities. And under a GREAT project, we were able to identify 60 VHT members per district. Next. After identifying the VHTs, we had to do the important role of training them. And after training them, the VHTs had to work with enough information. Some of the trainings were provided to the VHTs included, they had to reflect on their own gender norms, to reflect on mandate and role in helping adolescents access sexual reproductive services. 2, they had to receive short technical updates on health timing and spacing for birth and contraceptive methods. They had also to reinforce, during the training, we had to reinforce referral system and identify where referrals can be made. And on top of this, we had to create opportunities for VHTs to participate in community action groups at the community level, and this also helped to impact on their ability to deliver appropriate sexual productive services to the young people. In addition to the other part of the training, we oriented VHTs to use on the use of WHO and Ministry of Health free books and counseling tools. Next. However, there was a lot of barriers to accessing services, especially in the northern region. Some of the barriers included community and provider bias and stigma. There was the problem of distance, lack of transport or cost of transport. There was limited privacy and confidentiality. All of us know these are key important issues when we are working with adolescents. There was lack of autonomy to travel alone, and most important, there was lack of trained providers with knowledge on adolescent sexual productive health. Next. In order to help the VHTs work properly with the health facilities, the GREAT team had to first carry out activities at the facility level. One, rapid facility assessment, looking at the elements of youth friendliness was done. And based on this assessment, it was realized that we needed to improve provider attitudes and skills by providing trainings, focusing on using innovative approaches such as Pathfinder pathways to change game, toolkit activity cards, address norms and attitudes, in addition to sexual productive service provision skills. And we did not stop there, but now knowing that the VHTs were working with health facilities, we had to provide technical assistance to the health unit in charges and the district health team management, who indeed have the role of the coordination and supervision at the district level. What were some of the significant results that we got in the VHT contribution? One, 35% of newly married and parenting adolescents sought family planning services from a VHT or a health worker in the past 6 months. This was compared to the 19% expected in the absence of the intervention. Two, among those exposed, 42% more male newly married and parenting adolescents reported seeking family planning than female newly married and parenting adolescents. This again was compared to the 30% expected in the absence of the intervention. Three, proportion of older adolescents exposed who consulted with health workers about contraceptive use was also higher, although this was not statistically significant, 11% versus 6%. Next slide. Another result was how the adolescents the perception the adolescents had about the VHTs. In the qualitative assessment done, a small sample of adolescents reported that they had more trust and confidence in the VHTs. Two, they were more comfortable seeking services from the VHTs more than the health workers at the health facilities, though some still had that fear. Three, VHTs were considered more knowledgeable about sexual productive health than before. However, a small sample of VHTs of adolescents reported that some VHTs were still unwilling to provide contraception, and some still hold conservative and inaccurate beliefs about sexual productive health, and others uphold traditional gender norms in their advice and counseling. What were some of the lessons learned? Next slide. Or what can we take away from our experience of the VHTs? One, Working with VHTs and connecting with community action groups and other project interventions, enhanced community facility linkages, and support for adolescents' sexual reproductive health. In project design, VHTs were a scalable and low-cost intervention option. However, the project's inability to work more intensively with VHTs and inability to work with more VHTs limited effectiveness. Another challenge was that the project's scale-up strategy designed after implementation began did not align well with the VHT intervention. For example, some small local partners tasked with the scale-up did not have capacity to work with government health systems. So all these findings on coverage, gender equality, sexual reproductive health have several implications for the scale-up of great intervention and for the design and implementation of social norms intervention in general. Thank you very much.
Thank you, Emily. I think one of the things that I really like about the approach to working with the village health teams is reinforcing the notion that adults can be an important source of information for adolescents, can model change in their communities, and they're important frontline workers because young people don't always need to access clinical services. So to the extent that we can provide them with information and some services in places where young people are comfortable, I think that's a huge plus. Okay, and so we're going to go on to our next speaker. We're moving right along here. Back to the U.S. again, we're going to be hearing from Brad Kerner. Brad also holds a master's in public health, and he's worked for adolescent and reproductive health for over 15 years at both the clinical level, and he has particular competencies in adolescent reproductive and sexual health, male involvement in reproductive health, family planning, and HIV/AIDS prevention for youth. Brad specializes in gender mainstreaming and involving men and boys in reproductive health and women's empowerment programming, and he has specifically designed an approach to challenge gender norms with very young adolescents in Nepal, which has since been adapted to 6 countries. So Brad is going to talk to us this morning about the toolkit, the great toolkit, and some of the really interesting tools that have been developed that can be used by community groups to reach adolescents. So looking forward to your presentation, Brad.
Thanks so much, Kate, and it's such a pleasure to be on this panel with my fellow GREAT consortium members, but even more exciting for me to present on these materials since it's about 5.5 years ago we were so intimately involved in the ideation phase, the creativity phase, and I saw it through to the final printing and the use of it, and now the scale-up. So really excited to share this with everyone. So the toolkit was created to bring some fun and engaging activities to really transform gender norms and reproductive health outcomes. And they were created with a 3-stage process. One, we used information from a program review that Pathfinder led that really helped us see what was happening around the world and what relative materials were already out there that we could look at. Then we based it on the extensive formative research that the Institute of Reproductive Health conducted with adolescents and their influential adults for about the first year of the project. So we had really rich qualitative data from which to draw. And then we went into the development and the iterative process of pre-testing these tools, revising them, and really making sure that they were relevant for our key populations. One quick note as well is that we had 3 toolkits, one for very young adolescents, one for older adolescents, and one for the married and parenting. So here on the slide that you see are the materials that were in our toolkits. Specifically for the very young adolescents, let's first look at these flip books. They were really stories that you could tell young people, and they looked like a job aid or a flip book where a picture was on the front, but on the back side the reader could see the text of which they could read to the young people with a few trigger questions that they could ask to get a discussion going. So there was one for boys, one for girls. They followed the main character Okiti and Esther, who were also part of the radio serial drama. Then there was the activity cards at the bottom of the screen. These were, I describe them as a deconstructed curriculum. So there were about 20 different activities that young people could do in any order they wanted. So they weren't bound together in a book. They were separate. You can take one card out. You can do that activity. They knew if it was related to health or to puberty, or if it was related to GBV or to gender norms. I should mention the flipbook. Sorry, the flipbook also had each flipbook had 3 different stories in it related to those key themes as well. So one story on puberty, one story on gender norms, and one story on GBV. And GBV as it relates to their life stage, so harassment around puberty and teasing and bullying. Then you see this community game. This was a very large-scale game that was rolled out on the ground and could really engage a large group of young people to come watch the core players. And the players would also engage the larger group and draw them into the discussion that was ensuing from this game. Here you see it says "You're great" because we added a whole set of cards that talked about self-confidence and making people really feel great. And the last material in the toolkit was the radio discussion guides. These actually were not in the Very Young Adolescent toolkit, but they were in all the others. The reason they weren't in the toolkit was because our formative research pointed to the fact that younger adolescents really weren't listening to the radio as much as others and didn't have access to radios and control over what to listen to. So we used that research to make a decision to not spend money on printing out these radio guides and put them into the younger adolescent toolkit. But you saw from Camille's presentation, what we were widely interested to see at the end was there was over 73% coverage with very young adolescents. So something happened in this project that radio drama really did resonate with this age group, and somehow they got access to the radio at the time that the drama was on. So next slide, please. So the toolkit was really designed to be used within existing groups and that were already in the community. And for the VYA, that included school-based clubs. They were designed in that way so people could pick them up and use them. We didn't have to spend project time and resources creating new groups, training groups to function, figure out what they would do besides using our materials. So the idea was that our materials would take maybe 30 minutes of time of a group meeting that they were already having. So if it was a school group that met every week and they met for an hour each week, maybe they would spend 20 to 30 minutes using one of the activities in the toolkit. And the materials were flexible enough for them to use them as they wanted. They weren't instructed on how to use them and in which order to use them. Well, I shouldn't say how. They weren't instructed in which order to use them. So if they wanted to pull out an activity card this day, they could do it. If next week they wanted to do a whole school activity where they played the game, they were free to do that as well. The toolkit was used with this drop and go mentality, meaning that we wanted it to be easy enough for them to pick up and just use without training. And this was part of our scale-up strategy. What we found out was they needed a bit of an orientation to the tools since they were new. So we ended up having to do a half-day orientation. It wasn't a full-on training. It was just, here's how you use the tools, and now you can run with it. Next slide. We felt the tools in the toolkit, the materials were really relevant to them. One, because we based it on an extensive year of formative research. And we felt it was relevant because it was helping them learn about their bodies and puberty transitions and menstruation, so the reproductive health aspects of this age group, the GBV related issues to this age group, so harassment and teasing, and then starting to explore gender roles when they're really starting the ability to think that through and think through the expectations on them and whether those are fair or unfair. So it was really geared towards what was relevant for their lives and their life stage. It was relevant because it got them talking. In a previous conversation, we talked about the relational aspect. So the tools was really designed to get the boys and girls talking together around these same issues. And we inserted some behavioral catalytic triggers to get them to go and do something, be it talk to their parents about these issues or interview a village health worker to see what kind of services they could provide them or if they knew more about puberty. So we also inserted a lot of commitments that they would make, so behavioral commitments. So we felt it was quite relevant to their lives. Next slide. So in terms of the contribution that the toolkit made to our results, next slide. I'll first start with the exposure to the toolkit. So these are just the data from the very young adolescents. You see that over 40% of those VYAs that were surveyed were exposed. So just so you understand, we were sampling at the school level, not at the school club level. So to us, I was happy to see. And we know that not 40% of the school population are in clubs. It's a much smaller number. So this is good in my view, that the tools were able to get outside of the club into the school and possibly in the community in terms of reaching very young adolescents. So 40% were exposed to the materials. Of those exposed, 61%, so more than a majority, said they were exposed and use the tools very frequently or often. So that's as much as once a week even. So this is a good sign. If you're exposed, you're using it often, so that shows high demand and interest and the relevancy of the materials. Next slide. Oh, I could also say that males, you'll see in those numbers that males participated more in the toolkit. That doesn't mean, to me, that's an indicator that boys were more, they were attending the clubs more, attending school more, and I think it's more something to think about in terms of exposure and gender. Okay, so the use of the flip book. So a lot of this is based on our qualitative assessment at Nline. We found that adolescents were generally satisfied with their experience of the toolkit. The female participants recalled learning about menstruation, body changes, and pregnancy. The male VYA responded that the flipbook helped them to understand and not be afraid of body changes, such as wet dreams and their voice changes. There were some differing opinions between the sex and the age groups. So, for instance, girls liked the activity cards more than boys, but they also, some of the VYA girls didn't like the game because they didn't like getting a question wrong in front of a bigger group. It fed into a lower self-esteem, which is not what we wanted. But this wasn't the vast majority of girls. It was just highlighting some of the differences. On the slide, you can see pieces I've highlighted in green getting back to we were hearing that the tools really did help boys and girls talk. So that relational aspect, building respect between boys and girls, encouraging conversation, promoting unity and teamwork, getting laughter and friendship amongst boys and girls, fostering harmony. This is part of the work. This is part of the norm change. Boys and girls talking together, appreciating each other as humans, and seeing how they could grow up together in a more gender equitable way. Next slide. So here's just a nice quote from a very young adolescent boy. You can see this picture. He's looking at the flip book. I learned that work can be shared amongst boys and girls, and it has made me start helping my sister in the home or at home. So this is a quote about after being exposed to the toolkit. It wasn't that his parents were asking him to help. It was something he decided to start doing after being exposed. So here's a great picture of the game. So you can see how big it actually is. You see their sandals are holding it down in the corners, and you have a group of people gathered around it, and you can imagine you can have a much larger group as well gathered around. Here we hear that VYAS were reporting a decreased teasing of girls about menstruation and improvements in girls' self-confidence and positive perceptions of their bodies, and they were becoming more confident in themselves while in school and less fearful about what to do with their menstruation while in school. So you can actually skip the next slide. I'm noticing the time is going, and I want to give time to the next presenter. So go to the challenges slide. Yeah. Some quick challenges that are not unique to this project, but probably every ASRH project. Languages. So while the radio dialogue could be a dual language and everyone understands it, once it's written down, these aren't, the language becomes a bit more challenging because there's so many different ways in which you can pronounce specific words and write them. So, you know, it was just made it a bit difficult. Literacy could become an issue as well, although the very young adolescent group was the most literate and most able to use the tools compared to the older adolescents and married and parenting. We had turnover of our matrons and patrons who monitored and helped with the groups. And also we didn't have those radio discussion guides, which we realized would have been a great advantage for this group. And my last slide. So we reached 40% of the VYA in terms of coverage, but we're not so sure that's the key number to get to a tipping point, which means that you have enough coverage and young people exposed so norms start to shift at a much faster rate. So we're still thinking that through, and what would that number be? What percentage do you need to reach? Just to quickly end, I wish we had more time to simplify the language and budget for an iterative process of retesting the language, reprinting it, and I think that is something we could do in the future, and of course now including the radio discussion guides for those younger adolescents. So I'll say thank you to everyone and hand it off to the next presenter.
Thanks, Brad. I had the opportunity to observe GREAT in action about a year and a half ago, and one of the things that I just was fascinated by was this group of young people, primary school age students, that were talking, boys and girls, that were interacting in a very gender equitable way, talking about puberty with very little embarrassment. They were very articulate, they were very self-confident, they were very gender equitable, which I just thought was not something that you could make up for, you know, a visitor from the United States. We've been supporting some work with some research with very young adolescents through Johns Hopkins and WHO, and one of the things that they found in some of their data collection is that young people around this age of around puberty, there begins to be this separation of boys and girls, which young people are uncomfortable with, and they kind of miss the friendships that they have when they're children, and they don't always understand why there is this kind of separation. So this work of GREAT to kind of facilitate these kind of connections in very young adolescents, I think, are incredibly positive in terms of helping young people form and sustain these kind of gender equitable relationships. So our last presenter this morning is Sam Okello, who is also going to be speaking to us from Uganda. Sam is a research monitoring and evaluation coordinator with Georgetown University's Institute for Reproductive Health, and he supports IRH's projects to develop and test gender transformative interventions that are designed to improve outcomes related to sexual and reproductive health, gender equality, and gender-based violence among adolescents and youth in northern Uganda. His research experience includes post-conflict northern Uganda, which focuses on access, knowledge, and attitudes related to reproductive health. Sam is going to talk to us a little bit about how GREAT is now being scaled up, and I think this is one of the really exciting things about GREAT is it has been this deliberate attention from the very beginning about how we are going to take this innovative program and scale it up across different districts in Uganda. So, Sam, over to you.
Thank you, Kate. I'm going to speak about another interesting piece, which is scale up in Uganda and beyond. You have had a lot of good information about GREAT components, how they were designed and implemented during the pilot phase. Once GREAT was proven effective through rigorous evaluations. The consortium partners worked to leverage networks established during the pilot phase to scale up the intervention. Our scale-up strategy was based on the expand net motto, which is based on having a skilled resource team, providing technical support to youth organizations that expand the intervention. The scale-up major aim here was to expand coverage and institutionalization of great innovations and reach more young people or young adolescents. This goal was to focus on both horizontal and vertical scale-up, as the second slide. In terms of the horizontal scale-up approach, it seeks to expand the great package of interventions to increase the number of young adolescents reached over a broader geographic area. You could put the third slide, Sophie, please. The second approach of scale-up is the vertical scale-up, which seeks to integrate the elements of great intervention package into policies and norms in order to sustain the intervention over a period of time. For example, we work with government institutions and departments, like departments of community development, the health department, the education department, to integrate GREAT into their sector and meetings, and as well as activities and budgets, as well as work plans at district level. Our relationships during the scale-up process includes the international non-governmental organizations such as Institute for Reproductive Health, as you can see from the slide, Save the Children International, Pathfinder International, who provide support to the resource team. And the resource team are local NGOs. We are working with Concerned Parents Association and Straight Talk Foundation in Uganda, who were previously implementers of GREAT during the pilot phase. And these resource teams support the local government, as well as the new user organizations who are taking on GREAT expansion. All this resource team is advised through a technical advisory group, which is composed of experts, traditional leaders, and different stakeholders. But most importantly, also the funder, USAID, as well as the relevant ministry, such as Ministry of Health, Ministry of Gender and Labor, as well as Ministry of Education and Sports in Uganda. In turn, the districts coordinate and monitor the work of the user organizations in different parts of the districts. Meanwhile, the user organizations implement the GREAT innovation at community level. One thing to note about the user organizations who are expanding the GREAT innovation is that we provide them with training, technical assistance, and tools, but they do expand the GREAT model using their own resources, mainly integrating them to their ongoing activities. Next slide. So far now, we are about halfway through our year of scale-up phase, which includes rigorous monitoring, learning, and evaluation component to help us better understand the processes of scaling normative interventions. So our monitoring, learning, and evaluation includes looking at the feasibility, pace, coverage of expansion, fidelity, and adaptation, but also passing the baton and influencing on the receiving organization. As you can see from the screenshot that you have on your slide, is from a Google map, which we are using to monitor the coordinated rollout of great interventions components by various organizations in each of the districts in where we are scaling up in northern Uganda. This will be shared, the links to this Google Maps will be shared with you later in the webinar follow-up. Next. It should be noted that in shifting social norms, we should note that it requires more time, effort, resources, and even better diffusion strategies to reach out community-wide change. Also, we note that gender norms do really drive gender equality, sexual and reproductive health, and GBV outcomes. Yet, significant changes in underlying patriarchal social systems is unrealistic from short-term intervention. Also, it is still unclear to us when the intervention is most cost-effective or the benefits of addressing all the stages in tandem. So to design a sticky intervention for scale, you have to document the intervention steps so that it is clear what was piloted and how it was piloted. Also, you have to take into consideration the constant vigilance to feasibility of the intervention for future expansion. And lastly, there's a required frequent evidence-based discussions and iterations. Next. As we have expanded GREAT in northern Uganda, there have been initiatives to include the model also in projects in northern Uganda, such as Catholic Relief Services, which is an organization working in northern Uganda, is expanding the GREAT model to other parts of the region. But also, the GREAT model is being expanded beyond Uganda, such as Pathfinder is expanding the GREAT model in Mozambique. Save the Children is taking this to West Africa and the Democratic Republic of Congo. Plan International is expanding this in Benin. So as we can see, there's a great interest in expanding the GREAT model. So the consortium members came up and developed a how-to guide that has instructions, materials, and tools to implement GREAT components and values. This has been tested by user organizations in northern Uganda for over 3 months of using it. And we have made the revisions. Now it is simple and user-friendly. This guide will be available on the GREAT website around May. Thank you for good listening. Thank you, Kate.
Thank you, Sam. And wishing you all success in scaling this up across Uganda. I know you're already looking at taking this approach to other countries. So we have about 15 minutes left this morning. We are soliciting questions from the audience, but apparently we're having a little bit of a snafu with the chat box, so we're seeing lots of questions, but we're not able to field them and respond to them here. So Georgetown has asked me to let you know that we will be responding to your questions and sending materials and links with a follow-up email on Monday. But we do have a question about community action cycle, and one of our participants has asked if the community action cycle approach is similar or different to an approach that CARE uses, which they call, I'm trying to find the question. Sorry, there's a little snafu. There we go. What CARE calls the social analysis and action. And we'd like to pose that question to Dickens if he's online to try to give us some clarification if what kind of differences there are between community action cycle and the work of care around social analysis. So Dickens, what do you think?
Well, yeah, well, but I don't have very good knowledge of the approach that CARE uses. But the community action cycle provides the opportunity for the community to analyze the problem, come up with priorities in terms of how they want to solve the problem, and come up with the action plans. And then also they clearly define how they want to tackle the problem using partially their resources, but also now connecting the resource to the resources that the development partner has brought to their community, but also wanting to tap the resources from the local government or from the central government that could be at their disposal. So I don't know how the other approaches that, you know, how the other approach works, but if it involves analysis of the problem, possibly there could be some similarities, coming up with joint decisions by the community on how to tackle it. There could be some similarities. But the emphasis of the community action cycle is recognizing the gatekeepers who are the community leaders, both the social, technical, and even religious leaders and other leaders, to lead and champion the change that they want in the community. So I don't know how the other approach works. I've not had the opportunity to get to know about it and to use it. And the other important thing possibly is that you'll find that the community action cycle mainly also uses the PRA methods, participatory rural appraisal methods, at different levels. For example, at problem analysis, I see them use a lot of PRA methods. In evaluation analysis, evaluating together, they use mostly those PRA evaluation methods. Transect walk, you know, mapping, some of the tools I have seen them using. Thank you. My colleagues can feel free to supplement.
Brad, we just wanted to also throw this question out to you. If you have any other additional comments on how community action cycle is implemented by SAVE, might be similar and or different to the methodology that CARE uses. Brad, you're not there. Okay. Well, sort of just as I'm going on to the next question, I think you know, the community action cycle is a great methodology. It's very simple, it's very straightforward, and I think a lot of organizations come up with their own ways of trying to do this kind of social analysis, and so I'm not sure that there's one methodology that's better or worse than another, but I think what's really important is this really sitting down with community members and really working with them to ensure that the community's beliefs, values, etc. are reflected and that they're engaged in the design and development of any sort of approach, whether it's to reach adolescents or any other sort of social change activity in a community. So apparently I lied. We do have a few more questions. So we'll continue on for a few more minutes around dealing with questions. I want to ask another follow-up question to Emily. Emily, can you tell us a little bit about how you work with health center staff in the facilities to in turn support the village health teams?
Thank you very much for that question. In my presentation, I mentioned that, first of all, after we have identified and trained the VHTs, we do the mapping of the health facilities, because the VHTs are not really health workers, but they are community health workers who have been trained by different organizations like Pathfinder, so that they are able to be part of the community, because they live in the community, be part of the community and be able to reach the adolescents. So after mapping the health facilities, we also, during the trainings of the VHTs, we involve some health workers so that they know the issues we are passing on to the village health teams and for the purposes of follow-up to the village health teams. Another important thing we've mentioned is that the VHTs are a link to the community to the health facility. Their role is to refer adolescents to the health facility for more health services to be dealt with at the health facility, which the community, the VHTs cannot handle. So we not only deal with VHTs, but for partnership purposes, we work with the health workers at the health centers. We involve the DHOs at the district level, who are responsible for health services in the districts and at the community level. And on top of that, there are village health coordinators who still oversee the VHTs at the component. So we not only work with the VHTs, but even during our technical support of the VHTs, we reach the health facilities and see how they are working properly with the VHTs.
Thank you, Emily. We got a question about the tools, if those are open source, and yes, those are open source. They are available on the Georgetown University IRH website, and we will send those links out to with a follow-up email on Monday. There was a question about, let's see. How was expected calculated with the radio drama? Nana, did you want to take that question on?
Yes, thank you, Kate. So we actually did propensity score analysis. We initially wanted to look at the intervention versus control, but due to the broad reach of the radio drama, several of the control areas were exposed to the radio drama, and so we did propensity score analysis in order to get what would have been expected in the absence of GREAT versus what we saw in actuality.
Okay, thank you. Let's see, there was another question here. Okay, this is another question for Emily. What kind of techniques were used under GREAT to track the referrals that were made from community to health centers? I think this is an important question because sometimes we do this work at the community, but we're never actually sure if people are actually acting on that information and that referral. Were you able to track those referrals, Emily?
Yeah, the main purpose of the VHTs linking the community to the health facility is to handle the referral component. And one of the things we address critically in the training of the VHTs is we reinforce the referral system. We develop the referral tools, and the most important referral tool is the feedback, whereby when a youth accesses services at the health facility referred by the VHT, there is the feedback form which he brings where the health worker signs that this the docent has received the service, which is very, very important. Yes, there may be challenges in referral. Sometimes the health workers are too busy and they are not able to respond to the referral or to fill the referral forms. But this is a system that we really work on to develop the referral system tools, the referral books, and to make sure that we do the mapping properly to guide the VHTs where services are found for the adolescent to access.
Thanks, Emily. We also had a question about the most significant change methodology, and I think I'll direct that to Dickens. Where can people find out more about the use of the most significant change? Are you there, Dickens? No, Dickens is not there. You know, I know you can find this online because I know that a previous project I worked with, we did some work with using most significant change. So it's probably something you could Google, and yeah, I think it's something you can easily.
I can also, let me just point people, so it's actually a CARE methodology or supported.
Oh, it is, okay.
Yeah, so you can, it was a project, I think, by CARE and Oxfam. So it's, if you look for it, it's a guide to use most significant change by Rick Davies and Jess Dart. So people usually refer to it as Davies and Dart.
Okay, thank you. Okay, this is going to be our last question before we wrap up. One of our participants is curious to know. That's okay when I add the question and then the thing jumps. Here we go. Some people are curious to know about staff buy-in to the project, and how did project leadership ensure that staff fully supported activities? Sometimes staff are asked to promote practices and norms that they do not themselves support. So how do you ensure that the staff are committed? Maybe Sam can give us some insight into ensuring that staff at the local level are buying into the work that we're trying to do under GREAT.
Yeah, thank you for the question. So first, from the goal of GREAT is to transform gender norms. So first, we do believe that you have to be transformed first to be an advocate of gender norms transformation. So the project staff usually are the first to be taken through a transformation kind exercises and reflections on their gender norms perspective. But this is not done only at the beginning. This is done throughout the support of the staff. So in different meetings you have reflections, in different trainings and people continue to clarify on norms and their myth about gender. So this is what I can say, how we prepare staff to implement this.
Yeah, I think it's an important question. I think this is something we see a lot is we have to ensure that the staff that we're working with are really in tune with what we're trying to promote, and that their own biases, values, attitudes are addressed through training or mentoring or what have you. Okay, well, I'm conscious of the time. We have about 3 minutes left. I just wanted to kind of give you a couple of takeaways that I've picked up from the presentations here. Social change is really important to the work that we're doing to reach adolescents, unless we're really changing the environments in which young people live in terms of the attitudes and information and support that they get from their parents, from their teachers, from their religious leaders, from healthcare providers. We really can't expect young people to be able to act on the information that we may be giving them. Community engagement and youth engagement in this process is incredibly important, but there's no easy answers, there's no silver bullet, there's no quick solution to any of the things that we're trying to do. The layering of activities, I think, is incredibly important. All of these activities that are implemented under GREAT are very mutually reinforcing, so we're ensuring that young people are getting similar messages and similar support from different quarters of the community. And then keeping this eye on scale, and I've said this in other presentations before, that I feel like in some instances Africa is kind of a graveyard of pilot projects, and so really keeping an eye on taking these innovative ideas and making them simple and straightforward enough that other communities can work with them without huge inputs in terms of training and technical support. You know, I think this is one of the things that I really like about the GREAT project. It's intended to be something that communities can pick up and run with without a tremendous infusion of cash from an outside organization. And finally, that there's the need for tools that are age and developmentally appropriate, and I think, you know, GREAT did a really great job of segmenting, looking at very young adolescents, at newly married and parenting adolescents, and just ensuring that the tools and the approaches that were implemented for them were very specific to their particular needs, not just segmenting by sex. I'm sorry we weren't able to get to all the questions, but I know that the organizers are going to be sending a follow-up email next week to all the registrants with resources related to the presentations, as well as a recording of the webinar, and responding to any of the other questions that we were unable to get to in the course of this webinar. The email will also include some links to the VYA Alliance hosted Very Young Adolescent Sexual and Reproductive Health Resource Library Toolkit, which is on the K4H website, and also with information about the upcoming future VYA Alliance hosted webinars. So I just want to thank everybody. We had a pretty great turnout, over 100 participants that stayed with us for almost the full 90 minutes. And we look forward to seeing you in future webinars. Thanks so much.